Our next speaker up is Tristan Margetson, who is a senior pediatric perfusionist at Stanford University Hospital. She has dedicated her life to looking after the little ones. Those of us who work in pediatrics know that that's quite an undertaking. So Tristan is now going to continue this AKI study, but looking into transplant patients, which are their own challenge. So thank you much, Tristan.
All right. Well, good morning, everybody. It's so exciting to see so many people in the room and also at home online. I'll let you know right away, I'm working very hard to be my best self today because, of course, right before this conference happened, I got that call that said, we need you to go out in the field, cannulate a patient, and come back, and that took 24 hours. I got home about 6 in the morning and to pick up my bag and get on the plane, and my 8-year-old said, Mommy, you look really tired. And I said, oh, thanks, honey, I am. Why would you say that? And he said, your eyes are all black. So anyway, I made it here, and I'm really excited to share our data. It's interesting because it's pediatrics, but it's also interesting what we found for pressure, and especially for what we can do as perfusionists to make changes for our patients. We don't have any disclosures for this talk, but I will tell you that we collaborated with the Stanford School of Medicine on this. So our perfusion team, which is fabulous, and Mr. Don Sheff is in the audience, he had a hand in this too. And we worked with our PAC team, which is our heart failure team, to do this study. So it was great to all collaborate together. So I wanted to talk a little bit about how this developed. So if you've heard anybody ever speak from Stanford, they can't stop talking about how long our pump runs are. And that's actually true just due to the nature of our patients. We do a lot of pulmonary artery reconstructions there, but unfortunately our transplant patients are no different. It's the exception to the rule that you'll have a fresh chest. Almost everybody is a redo when they're getting a heart transplant in our pediatric population. And often we're going on bypass at the outset, even before we open the chest, because they're 5 or 6 time redos. So there's a lot of extra time spent on the pump, and half the time I'm looking at the pump thinking, what's going to go wrong and how would I fix it? And the other half of the time I'm looking, thinking, what could I do to make this better? And of course, AKI is one of those topics that everybody's thinking about, especially in the pediatric heart transplant population. Anywhere from 63 to 73% of heart transplant recipients have some degree of AKI after their transplant. In our institution, it was actually upwards of 73%. So 3 out of 4 patients had AKI at the end of their transplant. And as a result of that, they have prolonged ventilation times, they're on more inotropes, they have an increased length of stay in the hospital, they have a higher in-hospital mortality, and they have long-term inferior kidney outcomes, which is something that we don't want for people that have already been compromised. So in this area, previous research really placed the focus on what happened before, so pre-surgical risk factors. The fact that the patients all came in with low cardiac outputs. They might have been on bypass before. Maybe they're on a VAD, things like that. All of the studies were really focusing on what the patients came with, not what happened to them while we're here. So heart transplants by nature are all at risk for increases in AKI rates. And one of those are like the postoperative systolic and diastolic dysfunction that these patients experience once they have their transplants. They don't come out with a snappy heart right away. So they're already at risk for that. They oftentimes have low cardiac output syndrome related to that, or even more importantly, systemic venous congestion. We found that to be a huge factor, as you'll see in the coming slides. They're often on nephrotoxic medications, and they come into the operating room with pre-existing renal dysfunction. They're just not the ideal candidate. So when we got together, I ran into one of our PAC team fellows and I said, I really think we should look at this because I think something that we're doing, we'd noticed slight decreases in our rates of AKI. And I said, I think we're doing like something we're doing behind the pump is making a difference. And he said, okay, well, let's look at it. So the purpose of our study was to identify the perioperative and postoperative hemodynamic risk factors for AKI. So what we were doing in the operating room and what was happening in the ICU just postoperative. So we did a retrospective look at our patients between January 1st in 2015 to the end of 2019. We had to exclude some people, whether they got multi-organ transplants, if they ended up on ECMO right after we transplanted them, or if they passed within 7 days. These are the predictor variables we wanted to look at, what we wanted to study. One was their baseline demographics. what their clinical data was, and this was new. Nobody had ever really taken a look at what the operative variables on bypass were, and then what postoperative variables they experienced in the ICU. For outcome variables, we took a look at their primary development of AKI within 7 days of their operation, so the first 7 days after post-op, and then what their clinical outcomes were long-term as well. So what we looked at on bypass were what we were flowing, so what our cardiac index is. And in the pediatric population, you can vary how you flow. So in the adult population, we just don't flow by index. We sometimes flow cc's per kilo depending on the patient size. So we looked at that, whether it was cardiac index or total flow. We wanted to see what we were doing, as well as what mean pressures we were providing for the patient. Stanford is a higher pressure, higher flow institution by nature anyway. We do a lot of that, but we wanted to see specifically what those pressure targets were. I mean, I think everybody's wondering, like, what's the ideal flow? What's the ideal pressure no matter what you're doing? But we wanted to look at those with our heart transplant patients. We took a look at what the hematocrits are. Again, at Stanford, we love to jack up the crits. So we run it really high on bypass anyway, but we wanted to see if there were any target thresholds we could really drill down on. And we took a look at our renal nears, which seems pretty self-explanatory. Only in 2015, I'm happy to say now we have renal nears on every patient, but 9 years ago, we weren't always able to get those supplies or to trend that data. But when we did, we took a look and collected that when we could. But that was one of the flaws. We couldn't find as much data as we wanted in that area. And then we looked at how far we cooled, what our lowest body temperatures were at, and if that made any difference. And then we looked at how much phenylephrine was needed to maintain those blood pressures. So this was sort of our standard strategy. We were lucky at the time because we had the same physician doing, unlucky for him, but lucky for us. We had the same physician doing all of the transplants, so everything was pretty standardized. We did a standard cannulation dependent on what the anatomy was. So we sometimes accessed femorals, but mostly we did RA and SVC, IVC cannulation for everyone. At that time, we cooled everyone to 28 degrees. There were a few exceptions that had to be cooled lower based on their anatomy and what happened when they got into the chest. And we shot for flow rates when we got to that 28 degrees, somewhere between 100 cc's per kilo or an index of 1.8. On all these patients, we tried to have goal naps of at least 60. This was sort of a change to our practice. We had varied all of the naps based on patient size, but for these patient populations, for all of our transplant, we tried to drive the pressure up to at least 60. After we were rewarming, we had much higher flow rates, at least 200 cc's per kilo, or at least an index of 2.4. And then we gave neo in 5 mic increments to make sure that we maintained those blood pressures, even though we had high flows. As far as everything non-perfusion related, they did standard immunosuppression, which was 15 mg per kilogram of methylprednisone. We do a lot of plasmapheresis simply because our patients have already been exposed. So we did quite a bit of that for these patients as well. And then we maintained on their traditional immunosuppressive therapy. And as far as the statistical analysis, obviously I didn't do that. I can't even say the word. But somebody smarter at Stanford did that and looked at it. All right, so let's take a look at some of our data and some of our results. So in that 4-year period, we did 133 transplants, which actually was kind of impressive. We do have a high pediatric volume of transplants. We had 15 exclusions, whether they were ECMO death or a combined transplant. We do a fair number of heart-liver transplants based on our Fontan population, so those were excluded. So of those 133 that we studied, 64 of them developed AKI in the first 7 days. Now that sounds like a lot, but that was a drastic reduction in what we had done. Instead of 73%, it was down to 48%. But of those that did develop AKI, they tended to be younger, smaller, and they were more likely to be transplanted due to congenital conditions. So instead of having some sort of myopathy, like a cardiomyopathy, hypertrophic, restrictive, they were born with a disease process and they ended up having more AKI, which is sort of interesting. Contrary, we found no association between what sex they were, what race they were, what creatinine they came in with, whether they had a VAD, whether they had what degree of systemic ventricular dysfunction they had. That didn't matter. How many days they'd been on the wait list. And even more interesting, how long the donor organ was ischemic made no difference in their rates of AKI, because I would have thought that the longer, the worse functioning the graft was, the more AKI we'd see postoperatively, but we didn't see that. So of the patients, there was a range of how severe the AKI was. And of those patients that developed severe AKI, here's what we found. One, they had higher hematocrits. Now, we all run our crits on pump somewhere between 30 and 40. That's sort of standard at Stanford. And our anesthesia wants to come off, depending on the nature of the lesion, upwards of 50. So this was sort of new data for us to try not to get that hematocrit above 36%. This is sort of goes without saying, but the lower the renal body nears were, less than 60, you had worsening rates of AKI, more severe. So that makes sense. This was also part of it. The lower the body temperature was, anybody that was cooled less than our standard of 28, they had much more severe AKI than those that were not as hypothermic. And then also, this is really key data here. If your MAPs were less than 65, or if you had a really high CVP, most of the CVPs were trending what was happening postoperatively in the ICU. So after they had been transplanted and their heart was in, if they had high venous congestion, we saw severe rates of AKI. And also, this is another big take home for perfusion, which is high flows. Anybody that had a low mean cardiac index of less than 1.9 ended up with severe AKI. And then we looked at those patients that had no AKI, and they all had massive amounts of flow. So anybody that was at an index of 3.8 or higher had no AKI. This is sort of indicating, this is just a slide that we did graphically showing that the younger you were, and if you had congenital heart disease to start, all those risk factors to start, and then intraoperatively what happened as far as having a higher, the lower your cardiac index is, the more rates of AKI you had, lower your MAPs, the higher hematocrits, things like that. So also take home points. The odds of developing AKI were 4 times higher in those patients that had CVPs greater than 12. We had a great team in the ICU who studied those patients and looked at them. And as that CVP started to climb, they saw the AKI rate starting to climb as well. And also the odds of developing AKI were 5 times higher in those patients whose MAPs were less than 65. For those patients that did develop AKI, this is also not a big surprise here, but they were on the vent longer. They had a longer length of stay in the ICU, and they had a total in-house, once they went to the floor, they had a total in-house post-transplant length of stay. And also they had inferior survival rates as compared to those patients that didn't develop AKI. And this slide really shows that, which is the top line, which is the nice straight black line, shows that this is, so we followed them 7 years out. And so you can see that those patients that didn't develop AKI had much better survival rates than the dotted line, where the patients who had AKI and sort of would level off and drop and not survive as well. The other thing that came out of this is that we were talking about our degree of hypothermia. So a lot of institutions don't cool as much as we do. We have newer surgeons, and I think they feel like they want the time and the extra protection for cooling. But with the hypothermia, you get the increased afferent arterial pressure, you have tubular hypoxia, you have impaired renal blood flow autoregulation, and therefore you have renal medullary ischemia. Contrary to that, then you start warming them back up, you're on bypass, you cross clamp, we give tons of blood products, you've got the inotropes going. All of that means you have an immune activation, this oxidative stress, and an inflammation to the renal perfusion injury, and you have more rates of AKI. So this sort of led us to look and think, hey, let's not cool as much as we are going to on all of our heart transplant recipients. So the big thing that came out of our research and our study were that the intraoperative and the postoperative decreases in renal perfusion from a low cardiac output syndrome or from those higher venous CVPs, they play more of an important role in developing AKI than anything that the patient came in with. So any preoperative risk factors, it was more how we handled things in the operative room and outside that made a difference on whether they developed AKI. So again, in our institution, we were able to reduce our rates from 73% to 48% by taking those simple measures. And this led us to develop a renal protective clinical pathway for our heart transplant patients, as well as an institutional application of a renal protective clinical pathway for all of our patients. The things I want us to think about as perfusionists are: consider the mild hypothermia, flow high. high flow, and then consider what your target hematocrit should be, and that you really want to increase your MAPS. It seemed very counterintuitive to me as a perfusionist. I'm one of those minimalists. I don't like to intervene and do a lot of things unless I have to, but we definitely have to with some of these pediatric patients to drive their pressures up to maintain that tension so that they have lower rates of AKI. And finally, this is just what we developed. This is our renal protective pathway, and this extended from our perioperative surgery region into where we were in the CVICU, but we modified how they did the immunosuppression. We really focused on how we can contain and control the renal perfusion pressures. Obviously, we also made a move to giving aminophylline immediately during the perioperative, preoperative, and postoperative periods and for 48 hours afterwards, and then really focused on trying not to give those nephrotoxic medications. But all in all, I would say that what we took home is to flow high, keep your crit under control, and make sure that you control as much as you can. That's it. Thanks.